The next presenter will be Professor Tamir Ben-Chor, who is the head of the Department of Neurology and the head of the Brain Division at Hadassah Medical Center in Jerusalem. Holding an MD and PhD from Hebrew University, Professor Tamir Ben-Chor serves as a member of Scientific Advisory Board at Kadimastem. He is a global expert in the fields of neuroimmunology, neural stem cell biology, transplantation of stem cells in neural diseases, and neurovirology, and many more. So, Tamir.
Thank you. I was more than happy to come and with this invitation, and with a lot of respect to you, Michel. Michel, I've been working with Michel for several years now, and I must tell you, Michel is a role model. He's a role model on many aspects, but just to mention two that I think stand out is his interest, pure interest, where he goes in science with his heart, time after time, changes fields and gets into new fields and does great things time after time rather than continuing the same thing again and again. And that is extraordinary. And the second thing is Michel's unique ability to combine vision with practicalities. Because at the end of the day, we do science for the benefit of mankind, for medicine, for advancing medicine, and vision is not enough. You need to be practical in order to translate your science into a result that can be given as treatment to patients. And Michel has proven, as you have heard and more than once, his ability to do that. And it's simply enjoyable to collaborate now at Kadimastem and help with this such an important project. So I wish you many more years of hard work, which is hopefully wishing myself many more years of continued collaboration. I thought that to give a kind of an overview about the regenerative medicine for the brain, and not talking specifically on Kadimastem's work, because you will hear about that afterwards, but to give you a kind of a general idea. And the starting point was actually the ending point of several years of studies, that when we started with studying neural stem cells, it was the concept of what defines a neural stem cell, its ability to self-renew, and its ability to differentiate into different lineages. And the neural stem cell can differentiate into neurons, into astrocytes, and into oligodendrocytes. And when we started studying cells in animal models of multiple sclerosis, with the idea of a regenerative effect of a cell replacement therapy, we found different things. We found that these stem cells have therapeutic properties which were not known previously, and we were the first to describe them, mainly the anti-inflammatory or the immune regulatory properties of neural stem cells. And then also many labs, as well as us, showed their trophic effects, where they support repair processes in the tissue, not direct regeneration by the cells, but promoting endogenous repair. And we specifically were the first to show that they facilitate repair in demyelinating diseases, an animal model of multiple sclerosis. And this has become, these functional therapeutic properties, in my mind, came first as a part of the definition of a stem cell, because these properties are shared by different types of tissue stem cells, and they became the main rationale of current use of stem cells in the clinic. So I will talk about that, and towards the end I will also talk about the thoughts and the ideas that we have on the implications of these therapeutic properties on the role of stem cells that reside in the brains of all of us throughout life, and we are asking, what are they doing there? What are they there for? So, translating the immunoregulatory properties of stem cells, this is already an old cartoon where you inject the cells into the animal model of multiple sclerosis, and you get a significantly milder disease. You get alleviation of the inflammatory process, less T cells, less macrophages, microglia, and you get protection and reduced loss of myelin, reduced loss of axons, reduced acute axonal damage. And the thing is that this function is not species specific. You can use human neural stem cells on the mouse brain, and it works. And it's not a specific target molecule receptor effect. It's a multiple bystander effect acting on many different types of immune cells and in quite a non-specific way, and people are still trying to understand the molecular basis of this immunomodulatory effect. And this is an example of the trophic effect. This is a model of demyelination. This is the corpus callosum of the mouse. And then in the transplanted animals, in this case, the cells did not go into the demyelinated lesion where they were at the edges of it, but induced facilitation of the endogenous repair process of remyelination, and this is staining for myelin basic protein, and by this and other ways we show that it can facilitate the natural process of remyelination. So, as I said, we want to translate that into the clinic, and how do you do that? There are many considerations, okay? There are many different cellular platforms to use. One can use non-neural cells, the most commonly used mesenchymal stem cells, but already there are several startup companies working on placental cells and certainly on umbilical cord cells that share some of the features of stem cells. And there are the different types of neural cells that can be used. And then what is the effect that you expect? So I told you that the immune modulation and neurotrophic effect is shared by all types of stem cells. So these can be by neural stem cells and by non-neural stem cells. But the direct regenerative effect we expect only by neural stem and precursor cells being delivered to their natural environment. And then what do you expect, or how do you grow the cells? Where do you take them from? This can be tissue-derived precursors, and this can be from a line, like a human embryonic stem cell line, and obviously it affects the many aspects of standardization, aspects of the amount of cells that you can achieve, which is critically important for the success of treatment, and so on. And this affects whether the treatment is autologous, like mesenchymal stem cells can be given as an autologous transplantation, or allogeneic, the case of human embryonic stem cells. And this obviously affects the final commercial, but important clinically too. Will this be an individualized product, like autologous mesenchymal stem cell transplantation? You will need the patient to come to you in a specialized medical center where you can extract the cells from the bone marrow, from the fat tissue, grow the cells, wait several weeks or more, and then inject them back? Or is this a shelf product that you can deliver to the patient wherever the patient is, as would be the case with allogeneic human embryonic stem cells derived cells? And even within the neural cells, there are issues of where along the, the lineage should the cells exactly be. Neural stem cells, early neural stem cells have some immunomodulatory and trophic properties, but they are not migratory. And we have shown that the migratory property is critical for their therapeutic effect in vivo. Okay? They can inhibit immune cells in vitro, but they do not work in vivo if they are not migratory, at least in a multiple sclerosis model. In other diseases, it's obviously different. Along the glial committed precursor cells and oligodendrocyte progenitor cells, so these are the natural remyelinating cells. Both are migratory cells, but and both have, as I said, a potential for remyelination, but do oligodendrocyte progenitor cells have therapeutic properties like stem cells? I will show you in a minute, probably partially yes. And another issue that we need to figure out when translating the concept of this bystander immunomodulatory and trophic effect is the route of cell delivery. So we have shown in many studies the effect of direct CNS cell delivery to the cerebrospinal fluid. The cells disseminate throughout the neuroaxis. They reach in close proximity to most white matter tracts that are involved typically in the disease. They can migrate from there inside. The CSF is good for their survival. They can induce their effect through all mechanisms of cell action. And a major idea here is that you need to target multiple sclerosis, you need to target your therapy directly to the central nervous system. Because drugs like Rebif and all other drugs that exist today are very good in the early relapsing, remitting phase of the disease, where the disease is practically a systemic disease. Immune cells go from the systemic circulation, they go into the central nervous system and attack there. And all the immunomodulatory drugs that we have act systemically. When we reach the secondary phase of MS, it's a compartmentalized disease. The immune process attacks the CNS from within, and obviously we need to target the disease, the treatment to the CNS. Another major issue is patient selection. Our notion is that obviously for the early relapsing remitting phase, we have good drugs that postpone the shift, the transformation to the secondary progressive phase. Late secondary progressive phase, it's too late. The brain has degenerated, and this treatment, which is essentially a protective treatment, will not be effective. We look at the early secondary progressive phase as the optimal patient to take for treatment for several considerations. For example, also that in the relapsing remitting phase, the disease is very, very variable, heterogeneous, and you need a huge amount of patients to draw conclusions whether it's effective or not. In the secondary phase, and including in the early secondary phase, the disease is much more uniform, so you can prove whether your treatment is effective with a relatively small number of patients. Okay, just a word about ALS. All these considerations obviously are relevant for ALS, and these have been the major three approaches tried in ALS. This is CadimaStem's human embryonic stem cells derived astrocytes, the mesenchymal stem cells, both given intrathecally, and brave, courageous, how did you say about the Americans, performed in the United States by transplanting a neural stem cell line directly to the spinal cord tissue. And again, all these advantages and disadvantages, which I will not go through, whether it's a shelf product or autologous transplantation, where the procedure is easy, intrathecal administration is very easy. This intraspinal treatment is extremely difficult and with many risks. Again, this is allogeneic, this is autologous, but with the autologous mesenchymal stem cells, it's impossible to reach standardization of the cell product that you are delivering. So, switching to another point, people are looking mainly at what can my cells do. And we have done many studies and tried to make people look at not only what the cells can do, but what can they do in view of the environment that they are delivered to. Because the environment has many effects on the transplant, and this has to be taken into consideration when you translate that into the clinic. So, for example, the migration is highly dependent on the active inflammatory process in the tissue, and we have described specific cytokines and chemokines that attract the migration of stem cells along white matter tracts. The naive brain is not a friendly environment for stem cells, and with time they lose their therapeutic properties. I will come back to this point in a few minutes. The survival of the graft, or the question whether an allogeneic graft is rejected, the fate of the graft is very much dependent on the brain environment and exactly where you deliver the cells. For example, the hippocampus is a very friendly place to the cells, probably because it's a site of continuous neurogenesis, whereas the striatum cells do not survive. And again, in the hippocampus, stem cells are not rejected, even if they are allogeneic, and from the striatum, they are wiped out. Okay, so the environment is very important, which brings us to the next point. In order to develop treatment, you need an animal model. And most animal models for multiple sclerosis are good for recapitulating the systemic immune reaction against the brain, and the immunomodulation is again systemic. But there was no good animal model for the secondary progressive phase of disease, where we can ask questions like, does the environment allow the cells to continue doing the good things that they do? Can the cells retain and continue with their therapeutic properties? Because this is a chronic disease. And to answer the simple question that has not been answered until today, is regeneration, is remyelination possible at all in chronic MS by any type of therapy? And for that, you need a clinical relevant model of chronic progressive MS. And I will not tell you all the story. We have been struggling with that for many years, but more recently, this work done with collaboration with Siddhartha Chandran from the University of Edinburgh, and we had good reasons to think that this animal model of multiple sclerosis in a strain of mice called the Bayosi ABH, recapitulate many features of progressive MS. The course is relapsing, and then relapsing progressive, and then continuously progressive. We get typical MS plaques in the spinal cords of these mice, and with time they go from being chronic active plaques to chronic inactive plaques. You see a mixture of demyelinated naked axons and remyelinated, naturally remyelinated axons to some degree. In the chronic phase, you see closure of the blood-brain barrier, which is very important for modeling the disease. And pathologically, you see many things. This is just one slide. You see features of tertiary lymphoid-like organs which have been described and connected to the progression of multiple sclerosis. And we have studied this is in collaboration with Professor Ben Rubinoff from Hadassah and Chandran from Edinburgh, transplantation of human embryonic stem cells derived oligodendrocyte progenitor cells in this model. And now for the first time, we could see that if you deliver the cells to the naive brain, they will lose their properties. But as long as the brain has an active inflammatory disease, the cells continue to be active. Here, control fibroblasts don't do that. And this clinical effect is by various ways to look at it, all significant. You see the survival of these OPCs along meninges. You see a reduction in the inflammatory process in the spinal cord, and you see the protective effect of the transplant on the loss of myelin and axons in these mice. And again, making a point that the issues of cell platform and standardization are that important, we saw that the protective effect against demyelination is only in the most superficial layers of the spinal cord tracts. And in more deep layers, you have less demyelination, but also there is no clinical effect, because this is a bystander effect. And one of the reasons that this was only in the superficial layers, because our cells, with our way of growing them, did not migrate in and did not differentiate. And other people with other models could get OPCs that look in the dish exactly the same, but with their protocol of cell growth, the cells do migrate and do differentiate. So it's subtle things that need to be standardized. And the second point to make here is that I told you about where along the neuroglial lineage we need the cells. So with the human OPCs, we saw only the immunomodulatory protective effect. Transplanting mouse neural precursor cells, we could see both this immunomodulatory effect protecting against demyelination, but also a trophic effect with a significant increase in the number of remyelinated fibers, which we did not see with the OPCs. So the question of what is the exact cell platform to use is still open, and we need to pinpoint it better. Okay, so I want to go to the last part of my talk and ask, what does this mean about the role of endogenous neural precursors? a lot of interest, and there is a lot of literature about the regenerative properties of stem cells and their failure in the brain in various conditions, in adulthood and in chronic diseases and so on. But what about their functional, therapeutic, immune regulatory, and trophic properties that I just showed you? Does this have a role in protecting the brain, the aging brain, or the brain that is affected by neurodegenerative disease? And is there any failure of these cells in doing that? And this is a critical point for many reasons, which I don't have time to go into, but think for a moment that our brain is loaded with neural precursor cells. They are sitting there throughout life. Around 5% of our brain cells are precursor cells. We thought of these cells only for in terms of regenerative potential, but it's not reasonable, it's not logical that these cells just sit there doing nothing and waiting for injury in order just now to be involved in repair. This is not efficient, and then they fail in this repair. So it's very reasonable, and it has been suggested that these functional, therapeutic, immune regulatory and trophic properties of cells are not just by cells that are transplanted from the outside, but this is the functional role of brain precursor cells. And we need to look at that because it can be a therapeutic target. Okay, so again, we need to go to an animal model, and again, it's a long story, but in short, we went into a transgenic animal model of Alzheimer's disease. This is a mouse that carries 5 human genes which cause familial Alzheimer's disease, and we showed in continuation to others that at the age of 2 months, these brains are essentially normal. At age 7 months, there is severe amyloid deposition, gliosis, but no neurodegeneration yet. And at the age of 1 year, there is already significant loss of cortical neurons. So age 7 months looked as a critical time point to intervene or to look at the role of the endogenous neural precursor cells. So how do you look on the function of the endogenous cells? You examine their response to injury. So here the injury was an injection of lysolecithin several hundred micrometers from the subventricular zone, and examine the migratory response of subventricular zone neural precursor cells towards the lesion, a phenomenon that has been described many years ago. And at the age of 2 months, there is no difference between wild-type mice and Alzheimer mice. And at the age of 7 months, there is a severe loss in the migratory response towards the lesion. This is the wild type. This is the Alzheimer's disease mice. And then another way to look at the response to injury is to inject cytosine arabinoside, which wipes out stem cells in the subventricular zone, and see how these cells recover. Okay, so again, at 2 months, there was no difference between wild type and Alzheimer's disease mice, and at 7 months, there was a significant difference where the Alzheimer's disease mice had a significantly slower recovery. And of course, we can isolate the subventricular zone stem cells ex vivo and do basic studies ex vivo or in vitro for their functional properties, and we saw similarly loss of function. This was not easy to do because you need the cells very fresh, because what we saw is that once they continue growing ex vivo, they regain their properties. The loss of properties that we showed is reversible. It is mediated by environmental cues. I won't show you all the data for that, but the idea is that this is the basic concept of neurodegeneration. There is amyloid deposition in the case of Alzheimer's disease. It induces a toxic brain environment, and this induces neurodegeneration. Okay? And we say, okay, we have neural precursor cells. Their role is to protect the brain. But then the toxic brain environment, as we have shown, causes these cells to become dysfunctional, and dysfunctional resident neural precursors then fail to protect the brain, and then you have a vicious cycle. Okay? And the next step of the study is to see whether we can rescue that in vivo in the mice, and then the resident neural precursor cells will be a therapeutic target. So the last slide with where are things standing today. We talked about the concept of cell therapy for immune modulation and neuroprotection, and this is already in clinical trials in multiple sclerosis, in ALS, where Kadimostem and Professor Revel have an important contribution, and in multi-system atrophy, perhaps in other diseases as well. We are not there yet for cell therapy for direct regeneration, the cell replacement therapy. After more than 20 years, almost 25 years in the field, we are not there. The only clinical trial that I know of performed also in Hadassah is the use of human embryonic stem cells for age-related macular degeneration. And we have a roadmap for translation in other conditions. We are interested in MS. There is a European group that is trying to get organized for human embryonic stem cells in Parkinson's disease, but it hasn't started yet. We are a couple of $1 million away from that. And the future, possible future, is our ability to manipulate safely endogenous precursors. I say safely, meaning that not inducing tumors, and by that protecting the brain from various neurodegenerative diseases, and hopefully this will come as well. This is the Hadassah campus. This is most of the people who did really the work and the collaborators. And I thank you very much and wish you all the best, Michelle.